Hi, everybody, and welcome to this ADAA webinar. That's the Anxiety Depression Association of America. My name is Deborah Kisson. I'm the co-chair of the Public Education Committee. And welcome everyone to this webinar on needle anxiety. And so we're so happy today to have our presenters. First, Dr. Erica Simon is a licensed clinical psychologist with 15 years experience treating adults and couples. She completed her PhD at Southern Methodist University in Dallas. And Dr. Simon's expertise includes health psychology, medical anxiety, and needle anxiety. And then we also have with us today, Dr. Alicia Murray. And Dr. Murray is a licensed psychologist and director of the Anxiety and Depression Research Center at Southern Methodist University. And Dr. Murray is a leading researcher in the field of anxiety and mood disorders. She's published over 90 scientific publications and authored over 150 presentations at scientific conferences. And she's a member of the Anxiety Depression Association of America's Scientific Advisory Board. And so let's turn it over to our wonderful presenters and get to learning about the treatment for needle anxiety.
Needle anxiety and how you can manage it. It's a really, really important question to answer. So when you think about it, the invention of the hypodermic needle really revolutionized healthcare. It really did. So many things got unlocked with ways that we can really address medical needs by the invention of this very important device. But the thing is it really means that for a lot of people, if you have needle anxiety, it means that you have a range of unease all the way to potentially terror when it comes to medical procedures. And so the medical field or the medical world is just fraught with this. So the question is, how are anxiety and fear related? So fear is really when a danger is sitting right in front of us. And anxiety is when something that might be dangerous might be lurking right around the corner. And our brains try really hard to complete the picture. And so it makes perfect sense. When we're anxious, we're trying to figure out what is that going to be? What is that complete picture? What are we going to have to anticipate down the road? And we're really biologically wired for handling danger automatically and immediately. So this is something really important to understand because needle anxiety really taps into our fight or flight mode, or as we've now come to know it as the fight, flight, or freeze mode. So our bodies automatically and immediately leap into action when we're in a situation that feels scary. And our bodies do the exact same thing when we're anxious as we would do if we were fearful because there was danger right in front of us. So this is really important because our survival state, this is our brains and our bodies using something that's been evolutionarily adapted across millions of years. It actually uses this biological survival state in modern situations where there actually isn't any danger present. So it makes sense why we feel the way we do, because our brains are using a pretty new part of our brain, the prefrontal cortex that makes decisions. That part of our brain is really, really new. And what we're really doing when we're in situations that cause us anxiety, we're tapping into that millions of years of adaptation for us to survive scary situations. And if you think about it, this is one of my favorite things when I was doing research with Dr. Murray. So I was Dr. Murray's graduate student. And in the lab, one of the things that really, really stuck out to me is that until recently, until the modern times with the invention of medicine, somebody was coming at you with a sharp object, they weren't trying to help you. That just wasn't the case. So it makes sense that we are biologically wired to feel some anxiety and fear when somebody's coming at us with something that's sharp and pointy, like a needle. And then also from a survival standpoint, our brains are wired to be cautious. Our brains are wired to tend towards false positives than false negatives. And this again, totally makes sense. If I think there might be danger lurking around the corner and I don't go around the corner, I survive, I'm okay. It doesn't matter that there was no tiger around that corner. If I possibly have a tiger around the corner, and I go, it's okay, I'll go around there anyway. I could get wounded or I could die. So this is how our bodies and our brains actually, again, have an adaptive mechanism to really help us survive in physically threatening situations. And then anxiety paired with avoidance is actually a learning paradigm. And this is also something really important, because if you think about anxiety as a car, avoidance is the fuel. The more we avoid something, the more we're teaching our brains that that situation is objectively dangerous, and we only are surviving it because we're not going into it. That is what happens. It's absolutely what happens with needles, and it's really subtle. This is the thing. We have all these different ways our minds can play tricks on ourselves to tell, oh, it's okay. Who goes and gets an annual checkup anyway? I'm healthy, I'm young. We can tell ourselves that it's okay. I've never gotten the flu before, so I don't need to get a flu shot. We have these subtle ways that we actually avoid these situations. And when we do, what we're doing is we're literally teaching our brains that that situation is objectively dangerous, when in reality, it's objectively safe. So inoculations, blood draws, things like that, they're actually there to help keep us safe and keep us healthy. And our brains, every time we avoid one of them, it goes, it strengthens that connection that I'm not safe in those situations. On top of that, I think the other piece too is when fear is involved, our brains start trying really hard we get more into confirmation bias, the deeper we are into a fear response. And so at some point, when you have really strong needle anxiety, and then you're getting this information out there that vaccines aren't good for you, or, whatever it is, then all of a sudden, you go, aha, it's that thing. It's that little piece of our brain going, right, I don't have to do that. It's not because I'm scared of it. It's because it's not the right thing. It's not safe.
Yeah, Erica, do you want to add, more about your experience with patients suffering from blood injection injury phobia and the consequences of that phobia to their life, and explaining why this is not just, a fear one can easily overcome?
It's really, it's interesting. And thank you for bringing that up, Alicia. As I got into this research, we really, in a lot of ways, minimize this as a phobia, as a fear, and we see it as, the numbers. I don't even like to quote numbers of percentages of who has needle fears or blood injection injury phobia fears, because I think that they are dramatically under-reporting the actual amount of how much these fears impact our healthcare system and people getting medical care. I worked in a lot of healthcare settings in my training. Almost every training setting I had was in some kind of healthcare setting. And I was just amazed at how much this is actually really pervasive, but people don't really talk about it because they don't know. And so it's so easy to put off getting a blood draw. I mean, I have paperwork on my desk because I have to go somewhere and get a blood draw. It's so easy to avoid. And if you're anxious, I don't have these fears, but we just avoid without even, really knowing how easy it is to avoid. And there are people I've been called in and worked with. I got called in for a competency case in one of the healthcare setting in the hospital because there was a woman who was refusing life-saving treatment because she just couldn't possibly tolerate the idea of the needle. And when I talked with her, she's like, I know it makes no sense, but this is so terrifying to me. I cannot possibly imagine allowing this to happen. So she was totally competent to make her own medical decisions. And she was really just expressing, she's like, I don't get it, but it's just like, no, like just no. And again, I really do think it comes back to the fact that if somebody was coming at you with something sharp, it was probably to harm you. And that it's only recently and we have to use that prefrontal cortex. And then the other piece is that the bad thing actually happens. With the dog phobia, the bad thing doesn't happen. You don't get bit every time, right? If you have plane phobia, you are okay every time you take a trip. You might be using safety behaviors, but you're okay. What's really interesting about needle phobia is that you actually get the thing happens. And it's a thing that, and I'm going to talk in future slides about this, but it's a thing that really is aversive. And so if we're avoiding something that sort of kind of makes sense in our minds, and then when something does happen to us, we go, and we'll talk about the fainting response in a minute, but there's so much, this is so much broader than just fear and anxiety. And that's also a piece that people don't necessarily understand. And so we'll get to that in a moment, but I think just the piece about the gender, what's also interesting is that more women will report their fears. But when we talk about fainting, what's super interesting is that you talk with providers and they'll say that it is predominantly men who faint. They'll faint at their wife's childbirth. They're the ones, and they'll even say, the bigger they are, the harder they fall. And it's super interesting. So we'll talk about that in a minute, but there's some interesting kind of dynamics in that sort of the gender aspect of this as well.
If I can add to that, since Deborah, you brought up that on that radio show you listen to, there was this assumption of, well, don't be a wimp. And that's an interesting aspect because one could say that for blood injection injury phobia or just fear of needles, there's less sympathy from outsiders. When it comes to fears, a specific phobia, for example, of snakes, there seems to be more sympathy for people to understand why they're afraid of that. Because they, recognize this as there's a true potential of getting harmed, whereas with injections, we know that there is a very, very minor risk of getting harmed. We're getting these interventions in order to not get harmed, to understand better what is going on with us. And so this sympathy aspect, and sometimes this very demeaning approach from the public to say, what's wrong with you? Don't be a wimp. That doesn't help. And it certainly doesn't help, as Erica just pointed out, in order to seek help, to recognize it as a problem, maybe not even knowing it is one, and that treatments are available for it. And therefore seeking justifications, and maybe some of that justification being ill information or conspiracy theories, and as kind of a way of justifying why they're not going, when really it is just fear. And it's never, of course, just fear.
Right. It was a surprising level of lack of sympathy and shaming that, so it really, to help people get through this, the first step is realizing it really is that terrifying and uncomfortable. So if anyone's watching this, if you stopped right now and understanding you're not getting a shot because you're irresponsible or you're lazy, like who faces their biggest, most terrifying things. So even watching this and hearing the word needle is impressive if you're with us thus far. So we're here to validate this is very, very real and very uncomfortable.
Thank you for that. It's so true. Like there's that is what's so fundamentally it's interesting about these particular fears is that, like Alicia is saying, a snake phobia, you're trying to prevent harm. With needle phobia, with needle fears, we're actually trying to avoid something that we understand why it makes sense that we're scared of it. And by overcoming that needle fear, we're actually helping ourselves we're actually helping reduce harm by not avoiding medical procedures. And it's just such a important thing to recognize. Like, of course you feel this way. It makes sense. And there's a whole range. It's interesting. When there was one meta-analysis that found that basically every single child across all the studies had needle fears. And then those numbers reduced over time as you looked at older ages, adolescents and young adults, older adults, et cetera. But it's really fascinating. Every child had needle fears. And again, it makes sense. Of course we do. This doesn't, and we'll talk about why in just a second as well.
What I was just talking to my daughter's pediatrician the other day. It was so fascinating that, and my youngest is had been the most terrified of shots, but I think because she she had waited a while to get her vaccine. Her older siblings had got it. So it became this thing that, and also at her school that they offer them, the kids were just, because they were so excited to get it and because their older peers were getting it, that it was so fascinating, because that was like the exact same needle that 2 years ago dragging her in. So just seeing how that, I didn't point it out to her, but how that relationship shifted with emotionally her being so excited to be able to get it. So that was really interesting.
That's awesome. And it's true. I mean, these are fears that can be overcome. And again, that sort of idea of anxiety is a car, avoidance is the fuel. And the more we stop avoiding the situations, the more our brains go, this is objectively safe. It might feel uncomfortable. It might not, feel like the best, but I'm okay. So I think that's so awesome. And yes, getting all excited, having those positive emotions with vaccines is really cool. So I want to also bring up, Alicia was alluding to this earlier about how it's so much more than fear. So with some types of fears in phobias, it really is fear-based. What's interesting, all the people that I interviewed for our studies is super interesting. First of all, a lot of them said, this is a thing. I have a thing. There's a name for how I've been feeling. It was just amazing. And then a lot of them would describe it was so heterogeneous, meaning that just how people talked about what part of blood injection injury, fears, what they looked like. There was just a huge variation. I won't go into details, but it was really amazing how it's not just this really simple, basic, it's this way and it's this way for everyone. So a lot of them described, they're like, I don't know, I just get like this creepy crawly, or I just feel icky. It just feels icky. And it was fascinating to me how many people would say this particular, like they were trying to put words around it. And what's interesting is that with these fears, there's a disgust component. So disgust is a predominant emotion that really gets kicked up with this as well. And we're still, trying to really figure out and understand exactly how disgust plays a role. But again, it makes sense, pre-medicine, if you were encountering these sorts of things, you might be encountering a situation that might be disgust producing. And then there's this concept of a body envelope. So we have this sense of the integrity of our physical being. And this sense of integrity of our physical being, if we really think about our skin as a body envelope, we having any kind of violation of that body envelope is just inherently, again, from an evolutionary perspective, that's probably a bad thing. And let's face it, even for those of us who are not anxious when it comes to needles, getting needles don't feel good. They just don't. They kind of feel a little weird, at best, or, there could be pain involved. So this body envelope violation piece is really something that can really make sense, where we're going to want to avoid situations where that occurs. And again, our brains are dealing with millions of years of survival wiring. And the good thing is that when we understand why we feel the way that we do, that you feel the way that you do, if you're watching this and you have needle anxiety, once we actually understand why, that it makes perfect sense that this is how I'm feeling, what this means is that then we can use our newer parts of our brains, our prefrontal cortex. We actually get to override this biological programming. We get to make purposeful choices in these situations where we know they're objectively safe.
If I can add to that and again reiterate the point that you made earlier, because I think this is really so important. And again, for also the listeners here, is that when we talk about fear and anxiety, we talk about something catastrophic that happens as a consequence. So if someone is afraid of dogs, they're afraid of being bitten. If someone is afraid of social situations, they're afraid of getting humiliated. If someone is afraid of elevators, they're afraid of getting stuck in the elevator. For the majority of those catastrophic outcomes that a person with anxiety fears, the outcome never happens. They don't get better, or very, very rarely. They don't suffocate in an elevator because it's not airtight. It's rare to speak to a stranger and being publicly humiliated. It doesn't mean it doesn't happen, but it's rare. So those are rare. So the catastrophic outcome is rare. And that's why we as therapists know that when we do exposure, we can count on the fact that the feared outcome will unlikely happen. And the patient can learn that I can be in this situation and it is safe. It doesn't actually happen. Or even if it were to happen, I can actually cope with it because it's not as bad as I thought. What makes BII phobia out of fear of needles a little bit different, and again, Erica will explain a little bit more what makes this phobia, when it is one, unique, is that the perceived catastrophic outcome does happen or can happen. If a person fears to pass out when they get an injection, well, that is a realistic fear because many do. And losing consciousness, of course, is something that is unsettling. So what I'm saying here is that there should be no shame in worrying about feeling fearful of the outcome, because unlike some of the other anxieties or phobias, it can happen. But our point here is to illustrate that even when it does happen, even when people do faint, or even when they become very anxious, one can cope with it. And it isn't, and it's an anxiety that can be addressed and that can be changed.
Really true. And I do think that's, it's so much of our experience when we can normalize it, when we can validate it, when we can understand it, it can really dramatically change things. It gets us, again, it gets us out of, survival mode into, survival fear mode into that prefrontal cortex decision-making mode. And we're going to be talking about some techniques that can actually help you cope. Anybody who's watching this, if you have these fears, that can really help cope with this situation more effectively, and also can potentially really avoid some of the specifically the fainting response. So the fainting response, if you think about it, it's really disconcerting. And what often happens is, you have, before, a lot of people will report that they've gone to medical procedures before, gotten their blood drawn before, and then all of a sudden one time they passed out, and then forever after they pass out after that. And what's interesting about it, and what we'll be talking about, are some of the physiological mechanisms that actually make it likely that you'll continue to pass out if you have passed out. Because the advice and guidance that we get is actually 100% counter to not fainting. So we'll be talking more about that in a minute, but hopefully that also gives a little bit of hope out there as well. So
question for individuals with blood injury, needle phobia, and then the sub percentage that have a fainting response, what subcategory does the data show of people who have this fear phobia that then also have a fainting response?
I know there's a decent, Alicia, do you know the exact?
I mean, it's certainly quite prevalent. And
it's pretty high within that fear, a tendency to
yes, it's
faint.
pretty high within this population.
Okay.
And that makes it actually a unique fear among the anxiety disorders, because other patients with anxiety, this is a common fear to lose consciousness. It's common in, for example, also patients with panic disorder or patients with social anxiety. They feel as if they would pass out, but they don't. It's extremely rare, actually. So again, this fear of blood or fear of needles is unique because people do actually pass out. And Erica, if you can talk a little bit about the biphasic response and explain how this fear is different in that it's not just a fight, it's not only the fight-flight response, this activating phase, but there is also then this deactivating phase that actually leads to fainting.
Yeah, so fainting, it's a real phenomenon. It really does happen. And I worked with a lot of, in all the research that we did, that was part of my work, was to really work with people who were actually passing out, fainting in the lab. Lots of safety protocols, of course, but it's really interesting because when we have the fear response, we have all this cascade of physiological changes that help us to, in that fight or flight response, to respond to a perceived danger by fighting or fleeing. So we start taking in more air because we need more fuel in anticipation of more activity, physical activity, fighting or fleeing. We have, blood gets shunted to the major leg muscles, again, in preparation for fighting or fleeing. There's a whole ton of things that actually happen. Our sweat increases. There's difference in how the different kinds of sweat on different parts of our body actually change. There's tons of things that happen. Also, the prefrontal cortex, the part of our brain that does that top-down decision-making, it actually goes offline. And this makes sense. If there's a tiger right there, I should not be sitting here thinking about, should I climb the tree? Should I run? I shouldn't be doing any of that. So that part of our brain that has the decision-making goes offline. So all of this happens with the fear response. Now, what's interesting about the fainting response is that, and we're still trying to really understand, why is it, how is this an adaptive response? That's still a little unclear. Is it because we're, trying to, conserve blood by passing out or show an enemy that we're not a threat? We're still not sure. But what ends up happening physiologically is we have this strong counter response to the fear response. So all of a sudden, you have the dilation of the blood vessels, you have your heart rate slows, the blood vessels have dilated because that's how you get more blood to the major leg muscles. Then what ends up happening, heart rate starts slowing down, blood can really start pooling or getting kind of stuck in the legs, in the lower parts of the legs. You have less kind of return of blood flow to the heart and the brain. So there's actually a real physiological response. It's called vasovagal response. Fainting response is called vasovagal syncope. You can start getting that sort of narrowing of vision. And sometimes this can even happen, not related to blood, but it happens, quite frequently with individuals with these fears. So physiologically, your body is having all these changes that then lead to you passing out. And it doesn't even, sometimes you're just passed out for just a few seconds. It's not really a long time, but it is a real response. It's something that's happening physiologically. And so it's important to understand this, because when we talk about the interventions that can help you counter the fainting response, these are the things, the physiological changes we're precisely trying to address. What's also interesting is that hyperventilation is what occurs when we're in fight or flight mode, but we're not fighting or fleeing. So hyperventilation is when we bring in more oxygen than what is required for metabolic demand. And this leads to a whole cascade of changes. It's really fascinating. The more air we breathe in past what we need, actually, the less oxygen reaches our brain. It's really fascinating. The hemoglobin gets really sticky and it holds on to those oxygen molecules. And so less oxygen actually reaches our brains. And it's just this funny thing. And then CO2 levels get all out of balance. Elise, you can talk to that as well. And it again will be something that we're discussing, is how to avoid the fainting response. Because we really do have techniques. We have, our research has really shown, and other research has shown, that there's a way to prevent this.
Are you saying over breathing as well is associated with the fainting response? So controlling some of the, and maybe you guys are going to get to this, some of that over breathing can prevent the fainting responce?
Exactly.
We're going to get there.
Yes. So
wow. Okay. How fascinating. Yeah. Okay.
Elise is going to get really, it's going to definitely go over that in detail, because it really is quite fascinating. What do we get told when you're feeling anxious, getting a blood draw? What do? They tell you to relax and take a deep breath. Those are the two things they tell you to do. just relax. And then if you're anxious, they'll say, you know, just take some deep breaths, take some deep breaths. But what are deep breaths? If you're not,
yeah,
you're over breathing.
I wonder if these days when people are getting shots, they're wearing masks anyway, and it's harder to overbreathe in masks if there's less fainting.
That's a great question, and we actually looked into that. So you can still overbreathe through the mask.
You can still overbreathe,
yes, yeah,
even
but
through a
yes, yeah.
N95. You can still overbreathe. Okay.
Yes, yeah, but it's a great question. We were actually wondering about that. To what degree? It's actually very.
Does it help a little bit, or not even at all?
Well, minimally, because when people take deep breath, you very quickly actually.
Yeah, it happens quickly.
CO2
okay.
levels, yes.
Okay.
Yeah.
It's an interesting question, though. So
yes,
okay.
yeah.
Okay, so the good news. We want good news. Let's
let's
hear it.
Okay.
So these are the two techniques, and it's really about how do we counter the overbreathing, and how do we counter the physiological changes in our bodies that lead to less blood flow back to the heart and the brain. That's really the two strategies that we use. Both are evidence-based. Breathing retraining was actually devised. Alicia is one of the foremost experts in respiratory psychophysiology.
Amazing.
And it's really important because for her to be here, one of the reasons I'm so excited that Alicia is on here is because very few people really truly understand these nuances. And I remember when I first started in the lab, it was like I was trying to understand why not, you know, all the yoga classes I've been to where they're like taking all that yummy oxygen, breathe out all that toxic CO2, you know, big deep breaths. I didn't understand why. It was like, I really had to like switch my thinking.
Yeah.
It's really hard because it's as Alicia says, it's kind of like this biological error. Our brains, when we're taking in too much oxygen, we feel like we're not taking in enough oxygen. So we take in more, and it continues in this cycle and can even lead to panic attacks. So she will be able to grace you with her amazing knowledge and understanding. But this really is about, don't take a deep breath. And then, and so I'm going to pass it over to Alicia, and then we'll also talk about the applied tension after that.
So hyperventilation is a known term. It certainly has been around for a long time. Most people, when you ask them what is hyperventilation, they will say fast breathing, or they may say shallow breathing. I will talk a little bit more about what it actually is. But there has been decades of research that looked at the effects of hyperventilation, not just in psychopathology and anxiety disorders, but also in asthma, in cardiac disease, etc. And overall, we can say that hyperventilation is not a desired state. It indicates that the gas levels are out of whack. In anxiety disorders specifically, and particularly in panic, and myself and many other researchers in this country and in the world have looked at that. We know that there is a tendency in people that are anxious to not only hyperventilate when they are in a situation that makes them anxious, so basically in situations that trigger them, but also they can have what is called basic or basal hyperventilation. That means that on a habitual base, they breathe faster and deeper than the metabolic demands. And to give an analogy for that, which has been quite helpful to our patients, is it's a little bit like when you are standing with your car at a light and you keep your foot on the gas pedal. So you let the motor run, and eventually you kill the engine, right? Because there's too much fuel going into the engine, fuel that you don't need. So it's a kind of the same thing with breathing. When we sit, when we rest, when we don't actually use excessive, when we're not in fight-flight response, for example, where we actually fight or we run, but if we just sit there and we breathe, much more air than we actually need, then this will lead to an excess of air because we are not using it up. Now, what's really interesting is that the sensation of excessive air, too much air, more than the metabolism needs, leads to a sensation of breathlessness. And that is in some ways really like a biological error, because you should feel as if you're having too much air in your system, but instead you feel as if you cannot breathe. So you have the same sensation as a person that is actually suffocating. So the common suggestion of, take a deep breath when you're feeling anxious makes a lot of sense, in the sense that that's how people feel. They feel as if they cannot breathe. However, physiologically, it doesn't make sense, because the reason why they feel that way, the reason why they feel out of breath, the reason why they feel as if they're suffocating is not because they're breathing too little. It's because they're breathing too much. And again, this is not knowledge that we invented. This is basic textbook physiology. Of course, there have been many studies that have demonstrated this. So there are just a few examples here. So you can see when people, for example, we have done measured CO2 when people were engaged in driving phobia, they were hyperventilating much more than healthy controls. We saw the same in people with blood injection phobia. We saw the same in panic disorder. And again, not just us, but other teams. If you want to go to the next slide. So why is that, and how can we change that? For that, we need to know what is actually hyperventilation. And hyperventilation is not what most people think. And as I just said, most people think hyperventilation is just breathing too fast. So what should we do? Breathe slow.
Is this free Spira? This chart here that?
No.
Oh, okay.
That's my slide. Yes.
Oh, okay.
Yeah. So hyperventilation is not just breathing fast, and it's also not breathing just a certain amount of volume. What it is it's a combination of the two. It's the how fast a person breathes and how deep a person breathes, and that equals their CO2 level. And CO2 is basically like body temperature. There's a normal range, which is roughly around 40 plus minus 3 millimeter mercury. Anything that is above that range, so closer to 50, indicates that the person is not breathing enough. Anything that is below 37 indicates that the person is breathing too much. Yeah, so hyperventilation, in essence, is having lower than normal levels of CO2. And what we have found in our studies and other investigators is at this lower level of CO2 is not caused by the person breathing too fast. It's caused primarily by the person breathing too deep. In other words, too much air. Yeah? And you can see this in this slide. So you can see that this lower line is respiration rate, and you can see this person breathes, perfectly at 13 breaths per minute. So very, considerably slow, considerably steady, and yet the CO2 is going down. And it does that because the person is breathing way too deep. Yeah. But they don't feel that way. In fact, they feel as if they're not getting any air, because if your CO2 goes down, you will feel as if you acutely cannot breathe. Yeah, so that's why it makes so much sense to most, but it doesn't make sense physiologically. So what should you do? You need to breathe as little as possible when you're anxious or when you feel short of breath. Now, of course, this needs to be said with some word of caution. There are people that have conditions such as, for example, a respiratory disease or cardiac disease that where feeling short of breath can be an indicator that something's wrong. But even in asthmatics, in our studies, we have shown that most often when they're feeling short of breath, it's an indicator of them breathing actually too much. So you want to breathe as little air as possible. And yes, you want to not breathe too fast, but the more important thing is breathing more shallowly. So how do you do this? In the study that I developed at Stanford, we have a training. It's called capnometry assisted respiratory training, or CART, and it's a 4-week training where patients have a capnometer, which is a portable device that shows them their CO2 levels. And over the course of 4 weeks, they learn how to normalize their CO2 levels by breathing more shallowly. However, and this has been very successful in panic patients, we were able to also illustrate, and Erica was illustrating in her study with needle phobia patients with BI phobia, that even when you learn for 20 minutes how to breathe more shallowly, that you can already combat hyperventilation. So Erica, do you want to talk a little bit about that?
For one of the main studies that we conducted, that pardon me, that was really showed this technique to be really effective. I was amazed actually at how effective it was in a single session. So to help people who are a part of the study really stay in the situation that was causing them anxiety. And then in my own practice as a clinician, I've used this many times, and it's pretty amazing how with just some simple tweaks, we can really get to an understanding of how to counter the things that lead to the fear and the fainting. One thing I want to point out is deep breathing versus shallow breathing. It's something that we kind of, there's two different ways that we conceptualize these two ways of breathing. So we'll say shallow breathing we mean we're breathing up here in our chest and not in our abdomens. Shallow breathing, the way that how we're discussing it is really focusing on, we want to breathe with the abdomen. And in fact, part of how we counter the hyperventilation response and the fight or flight response is that we breathe with the abdomen and not with the chest. Because when we breathe when we're scared, our breathing moves into the chest area. And this leads to things where we're like kind of taking these small, shallow breaths in a way, but they'll still be big. So they're shallow up here, but they're still big breaths. They're breaths that are beyond what we need for whatever physical activity we're engaging in at the time. So I think that's really...
The way you can think about deep is deep volume wise. So in some ways, it's if you think about our breath being a glass of water, you can drink a really large glass of water, which would be a big breath that would be taking in a lot of air with the inhalation. Or you can think about it as a small glass where you inhale or sip in this case, very little air. Yeah.
Is it fair to think of it as intensity, like very intense versus gentle?
No, it's really all about
it's
volume.
Really about
and
volume.
In some ways,
so it's the volume.
It's really the volume. Yes. Yeah.
Okay, so the volume. Okay.
Yeah, the volume.
One of the tricks that I use when I'm describing it is there's, you think about waves on the ocean, and the waves can kind of come crashing in on the sand, or the wave can just slide in in and slide out. And that's how I think, like a visual, it's you want the sliding in and sliding out. It's just a small amount. And it really is, it's not that wave crashing, but when we're anxious, it's the wave crashing. We're going, and it doesn't even have to be that obvious. Sometimes it really is these subtle ways that we dysregulate what's called that blood gas exchange. Oxygen comes in, it goes to the tissues, gets utilized, makes CO2, and then that gets breathed out. When that exchange, when that balance gets off kilter, that's the problem. So we want to just be that gentle air in, if that's how you want to think about it, but it really is associated with the volume. So that's just small little wave or that little sip of water. So when
many clients ask, like yourself, well, what would that feel like? Or when do I know that I'm breathing too deep? You will know when you hear yourself. So first of all, you never want to breathe through your mouth, because that increases the likelihood that you will take in more air, larger amounts of volume. It's easier to do that when your mouth is open. And of course, you need that when you're running, for example, right? You need more air. So yes, it makes sense to breathe through your mouth. But otherwise, we should always breathe through our nose. And this is when you look at babies, for example, or young children, you will see they don't breathe through their mouths. They breathe through their nose naturally. We adapt that as we get older, but it's not meant that way. We are meant to breathe through a nose because our nose has a filtration system. That's why we have that nose in the first place, to kind of, purify what's coming in, to avoid, things coming in that we don't want, but also to smell, of course. So when you breathe through your nose, which would be the first step, close your mouth, breathe through your nose, and you can hear your own airflow, you know that you're breathing way too much, because you should not hear anything. In fact, just as Erica said, the air should slide in and should slide out. There's no effort. And it doesn't even, in many ways, you automatically do not engage then in just breathing, because that would mean you're lifting the torso, and that would mean you're getting more air volume in. So in essence, there is no movement. When a person breathes at the rate and volume that they're supposed to breathe, you will see no movement, neither in the chest nor in the abdomen. It can help to have this tactile feedback from the abdomen, but it's not really necessary, because again, it will be so gentle, so subtle, that there will be just very little movement. Now, of course, that's easier said than done when, that sharp object is coming at you. And maybe Erica, you can talk a little bit about that more, what to do in order to, prevent then to take these big gulps,